Assalamu alaikum. Our second lecture in pediatric tropical diseases will be about Leishmaniasis and Schistosomiasis. Firstly, we'll talk about Leishmaniasis. The objectives of this lecture will be, we will talk about etiology and transmission, epidemiology, life cycle, clinical manifestations, complications, laboratory diagnosis, treatment, and prevention. Etiology and transmission. Leishmaniasis is caused by an intracellular protozoa of the genus Leishmania. It will lead to mucocutaneous Leishmaniasis or visceral Leishmaniasis. It is transmitted by the sandfly phlebotomys أو تسمى الذبابة الرملية. This is a photo of sandfly. Epidemiology. It is endemic in tropical and subtropical regions. In Sudan, Leishmaniasis is endemic in Gadarif, Sinnar, Blue Nile, South Kordofan, and North Darfur states. There are two types of Leishmaniasis. One is called Old World Leishmaniasis and New World Leishmaniasis. Old World اللي هو العالم القديم يعني mainly Leishmaniasis types are Leishmania major, Leishmania tropica, and Leishmania ethiopica. These three types cause cutaneous Leishmaniasis. Leishmania donovani causes visceral Leishmaniasis. In New World Leishmania caused by Leishmania mexicana and Leishmania brasiliensis. Life cycle. We will concentrate on the life cycle of visceral Leishmaniasis or Calazar. The parasite exists as a flagellate or what is called promastigote. It has an flagellum in the insect vector, and as an aflagellate, amastigote means it has no flagella in human cells. After insect bite, the promastigotes, which has a flagella, will enter the macrophages. It will lose this flagellum and change to amastigote, multiply there in the macrophages. Then the macrophages will rupture, releasing these amastigotes that infects other macrophages and cells of the reticuloendothelial system, which are, as we said before, the liver, spleen, and bone marrow. This picture shows the life cycle in human. Step 1, sandfly takes a blood meal and inject a promastigote in the blood. The promastigotes are phagocytosed by macrophages or other types of mononuclear phagocytic cells. The promastigote will transform into an amastigote. Amastigotes will multiply in cells of various tissue of reticuloendothelial system, and then it will rupture. Another sandfly will take blood and will take with it the amastigotes. Here ingestion of parasitized cells. The amastigote will transform into promastigote. As you can see here, this is the flagellum, and they divide in the gut and migrate to the pharynx of the sandfly, ready for a new cycle. Clinical manifestations. Incubation period is between 2 to 8 months. Fever, loss of weight in spite of good appetite. Epistaxis, huge splenomegaly, hepatomegaly, pallor, and lymphadenopathy. This is a photo of a child with Calazar. As you can see, this protruded abdomen is due to huge splenomegaly. Complications: heart failure due to severe anemia, secondary bacterial infection, which is usually the cause of death in cases of Leishmaniasis, hepatocellular damage. Laboratory diagnosis: complete blood count. We will find pancytopenia, which means low hemoglobin, low WBCs, and low platelet count. Raised ESR, aspiration of lymph node, bone marrow, or spleen to detect the A mastigote or the LD bodies. The most sensitive sample is the spleen aspirate, but it is not done because it may lead to splenic rupture and it is a very dangerous procedure. Serology, detection of the antigen, which is called RK39, detection of antibody by DAT test or direct agglutination test called DAT test. PCR, the detection of DNA. Treatment, first line is sodium stibogluconate plus baromycin sulfate for 17 days. Second line is amphotericin B. It is used for resistant cases. Prevention, insecticides to get rid of the sandfly, insect repellents, impregnated bed nets. Early diagnosis and complete case management is an important way of prevention. No vaccine yet. Thank you. Our second talk in this lecture will be about schistosomiasis or bilharziasis. We have the same objectives as previously mentioned. Firstly, we will talk about etiology and transmission of schistosomiasis. It is caused mainly by Schistosoma hematobium, Schistosoma mansoni, and Schistosoma japonicum. There are other types, but these are the three main types. Transmission to human is through contact of skin with water contaminated with Cercariae, which is an infective stage. Epidemiology, schistosomiasis infects mainly children and young adults. The peak age of incidence is between 10 to 20 years of age. Irrigation projects provide a broader habitat for snails. عشان كده الشيستوسومياسيس usually found في المناطق اللي فيها الترع والمشاريع الزراعية وكده يعني اللي هي where we find these snails, which we, as we will see, it is the intermediate host in bilharziasis. Life cycle. Human is the definitive host. As we said, the definitive host اللي هو where the sexual phases of life cycle occur. Snails are the intermediate host. Cercariae will penetrate the skin, then change to schistosomule that goes to the lungs, then to the liver, and mature to adult worms in the portal vein. Adult worms migrate to perivasical plexus in case of Schistosoma hematobium and to mesenteric veins in case of Schistosoma mansoni and Schistosoma japonicum. After fertilization, the eggs will penetrate the bladder and the intestine and appear in urine and stool respectively. In fresh water, eggs will hatch, a motile miracidia will be released, which will infect specific snail for each species. After 4 to 12 weeks inside the snail, an infective Cercariae stage will be released. As you can see in this picture, this is a life cycle. This is the Cercariae with the forked tail and the ذيل مشقوق. It will penetrate the skin. The Cercariae will lose its tail and become a schistosomule. It will enter the circulation, then migrate to the portal blood in the liver and mature to adults. Paired adults اللي هم دايما بيتواجدوا مع بعض يعني مع الميل and female. Okay? They are found together all the time. The paired adult worms will migrate to mesenteric venules of the bowel or rectum, laying eggs in the circulate to the liver and shedding stool, or to the venous plexus of the bladder and to be shed in urine. Okay, this is a specific egg for each type. It is released in water, fresh water. The egg will hatch, releasing a miracidia, which penetrate specific snails. After maturation, a Cercariae will be released ready for a new cycle. Clinical manifestations. Patients with schistosomiasis may be asymptomatic, but the patient might have swimmer itch, which is dermatitis, as a site of entry of cercaria. Katayama fever, which is a serum sickness-like disease, 4 to 8 weeks after exposure, characterized by fever, chills, and sweating. Terminal hematuria and dysuria in case of schistosoma hematobium, colic abdominal pain, bloody diarrhea, hepatosplenomegaly in case of schistosoma mansoni and schistosoma japonicum. Complications. The patient might present to hospital with these symptoms. As we said, maybe asymptomatic early, يجي في المرحلة بتاعت complications اللي هي mainly portal hypertension and esophageal varices, and the patient might come with hematemesis in case of schistosoma mansoni, and he might present with chronic renal failure and carcinoma of the bladder in case of schistosoma hematobium. Transverse myelitis is a rare complication. Lab diagnosis by detection of eggs. In case of schistosoma hematobium, eggs with terminal spine in urine, or in chronic cases we might need to do cystoscopy and biopsy. In case of schistosoma mansoni, eggs will be found in stool, specific eggs with lateral spine, or we might need to do a proctoscopy and biopsy. This is a picture of eggs of schistosoma mansoni with a lateral spine, as you can see, and this is schistosoma hematobium with a terminal spine. This is japonicum with a lateral small spine. Treatment of choice is praziquantel tail taps. Prevention, it is done by improved sanitation, eradication of snails, and effective case management. Thank you.